our February Children's and Women's Research Lunch and Learn. I see folks starting to trickle in. Um, very excited for our topic today, which we have three presenters for. Today, you're going to hear a presentation about language and inclusive research practices, some stories and strategies from different C&W affiliated research teams. I'm going to introduce our three presenters today. Cynthia Liu is a project coordinator at BC Children's Hospital Research Institute, supporting language inclusive pediatric research through the Multilingual Research Team Pilot and the Language Barriers in Research Initiative. Rebecca Courtemanche is the clinical research manager with the Division of Plastic Surgery at BC Children's. The division includes 7 surgeons and 2 research staff. Rebecca and Kathy. Through her work, Rebecca has learned the importance of asking, who are we not able to recruit, and how can we make things easier for patients to participate in order to increase research participation and produce study results that better represent a patient population. Lastly, Sahel Mirrazavi is a recent biology graduate from the University of British Columbia and a research assistant with the British Columbia Karma Chiwos collaboration known as the BCC3 study. Her work centers on health equity and language access through community-based research. She has experience working with diverse communities within health systems and has a particular interest in how to incorporate community voices in language translations that better shape patient experiences and outcomes. I am your host today and facilitator, Nicole. I'm from the WHRI. And just in terms of format today, we're going to have these three folks present. But if there's something that comes up for you, a question that's top of mind, please do just pop it in the chat and we will get to it after they're done their presentations. But feel free to name an actual person if your question is specific to one of our presenters. Next slide, please. And before we get started, I do want to gratefully acknowledge, with respect, that where I'm joining from today on the unceded ancestral and occupied lands of the Coast Salish people, which include the Musqueam, Squamish, and Tsleil-Waututh nations. Yeah, just grateful for the original caretakers of these lands, and want to just reinforce, I think today's topic of doing research in an inclusive way in language really does kind of speak to some of our own institute level commitments at both BCCHR and WHRI. And just to acknowledge that this past weekend was the Women's Memorial March, which does really recognize the intersecting harms that can affect Indigenous people, and just reinforce our own role as researchers to do trauma-informed and inclusive work. Next slide, please. So without further ado, I'm going to pass it over to Cynthia Liu, who's our first speaker. Over to you, Cynthia.
Hi, everyone. So my name is Cynthia. Can you hear me okay? Yeah, okay.
Yes, we can.
So today I'll give you guys a quick overview of the Multilingual Research Team, or the MRT pilot study, and share a few best practice when working with interpreters during study visits. So a quick intro to our team. So I'm the project coordinator for this team, and then Jennifer Clayton, who's also also here today, is the director of the clinical research operations, and Dr. Quinn Doan is our PI. So this pilot is also supported by our multilingual research assistant team and our family advisory group. We are also receiving guidance from the IDEA Allyship Advocacy Working Group. Oops. So for today, I would like to cover 4 things. So first, what MRT is and why does this matters? And second, when to use MRT for language support. And third, a couple practical tips for working well with an interpreter during study visits. And lastly, how to access MRT support if your study needs it. So for some backgrounds of this project, MLT is built on a series of pilot studies that our team has done over the past 2 years under the language barrier in research initiatives. And we have interviewed researchers, families, and youth to better understand what gets into the way of including families with limited English proficiency and what could actually make it easier for a research team to do this well. We also conducted a national survey and then a local pilot with 9 of our local research team to test interpretation and translation supports. One of the key findings was that 73% of the researchers are actually still excluding families with limited English proficiency, even when they want to be inclusive. When we asked why, the barriers were time, cost, uncertainty about best practice, and also a lack of clear support. So that's why we developed the MRT pilot. Our aim is to make pediatric research more inclusive by creating a more sustainable and centralized way to access language support. So more about the MRT pilot study. Our goal is to build and test a centralized team of bilingual research staff and students who can support multiple studies at the BC Children's Hospital. And our aims are support researchers in multilingual study activities, increase participation of families who speak languages other than English, and evaluate how feasible, acceptable, sustainable is this team to our community. So who's involved in our pilot? So these are the three groups of people who are involved in our pilot. So first, the researchers and the research teams who are seeking language support. And second is our MRT members who are bilingual staff and students who are trained in research processes and ethics. And third, family advisors who are providing us with lived experience and cultural guidance. We want to make sure that all our work is not only accurate to the language, but also culturally appropriate and respectful to how it lands with the family. So, emergency support and when to use it. So there are three main types of support that we are able to provide for research teams. So first, it will be interpretation. So this would be any live interpretation support staff for like research interactions, such as consent meetings, study visits, or follow-up calls. So second will be translation. So this could include translation of participant-facing materials, like the consent form itself and the surveys. And third, that is, MRT members can also act as a research assistant on behalf of the study team. So this is a little bit different from the interpretation because the MRT member is supporting the study task as a delegated role. But this, just to note that this does take some time to onboard the staff and also do all the training ahead of time if you are interested in doing so. Regarding when to use MRT, we can support language inclusive activities like consent discussion, study visits, follow-up calls, participation communication, translation of study materials, and transcription for like multilingual qualitative work. And there's also more things that we are able to do. Um, just to note that our service is availability depends on the study needs, timing, and our RA availability. So when you submit a request, we would confirm the details with you and discuss what is feasible. So now let's move on how to work with an interpreter. So these are like some small strategies to support accurate interpretation and help reduce miscommunications during research discussion. So first, researchers should speak directly to the participants instead of towards the interpreter and maintain eye contact with the participant. This would keep the family and also the participant the relationship between the research team and the family and the participant, and with like the interpreter supporting the communication. So second, please use short chunks of words instead of a full paragraph, and pause often. So there's time for the interpreter to talk to the participant in between. So interpretation is most accurate if we speak in smaller pieces instead of one big paragraph. So third, keep your normal pace and tone. So because the interpreter will be the person managing the language part, so you don't need to slow down dramatically or speak louder. You just basically follow your normal speaking speed. And fourth, use the teach back once or twice to confirm understanding. So for example, you can ask, just so I know I explain it clearly, can you tell me in your own words what the study is about? So teach back is a really good way to check the participant if they actually understand what the information is. This is not to intend to test the participant, but just to check in for us to know we explain it properly and they understand what we're saying. As for what to avoid having side conversations with the interpreter. Um, if anything has to be clarified, you can do it transparently and involve the participant. Please avoid long paragraphs without pausing. Avoid saying ask them if to the interpreter because it shifts your attention away from the participant. And finally, please do not treat yes as a proof of understanding. People often say yes to be polite, and even if they don't understand fully. So please use the teach back method to make sure that they understand clearly. So what if a participant declines to be an interpreter? Sorry, declines using an interpreter. So sometimes the participant would say, "Oh, I'm actually good, so you can just talk to me in English." Um, Even if like their English is not their first language. If that happens, first confirm their preference. Would you like to continue in English today, or would you like an interpreter? If they still say yes to English, please proceed in English. And second, it's important to document um, that like an interpreter was offered but was declined. And third, use plain and simple languages and the teach back method to for the key points, especially around study purpose, what the participation involves, risks and benefits, and voluntary participation. And finally, if you cannot confidently confirm understanding, especially for complex discussion or consent, it's appropriate to pause and reschedule for interpretation support rather than pushing it forward. So for also for like just for you guys to know for our future plans, we are planning to develop interpreting training videos so people can use it later on for onboarding or like other training or refresher purposes. So I'll end here with the languages like we're currently providing to and also how to access the MRT project. So these are the current languages we're providing for translation and for interpretation. And if you're looking for language support for your study, or if you're interested in learning more about the MRT pilot study, you can email us at the mrt@bcchr.ca, or you can scan the QR code here, and then you can fill out the registration form. After you submit the form, we'll follow up to confirm the details of your studies, timing, and what support would fit best for you. Thank you so much for listening, and please let me know if you have any questions so we can like answer at the end of the presentation. Thank you.
Hi everyone, thanks for starting us off, Cynthia. That was a great talk. Today I'll discuss how our team is using available clinical and research interpretation tools to maximize participation in research. Next slide. So I'll talk about our study on creams, lotions, and balms for children with post-burn itch and how we made use of clinical and research interpretation tools for the project. The study is led by Dr. Erica Henkelman and Dr. Sally Hines. Kathy Vong and I are the research staff members. Marcus is an SFU undergraduate student and Chian is a biostatistician. And this project is in part supported by the BC Firefighters Burn Fund. Next slide, thanks. So brain injuries are relatively common within the pediatric population. After the wound has begun to heal, a large majority of patients deal with mild to severe itchiness itchiness at the site of their burns, and this can be detrimental to a child's sleep, attention, or psychosocial well-being, and itching can damage the healing skin. So at children's plastic surgeons, they treat the newly healed skin by frequent application of over-the-counter moisturizers, but there's no real consensus as to which moisturizer is the most effective, and the creams actually vary quite widely in terms of cost. Next slide. So therefore, we aim to compare the efficacy and patient satisfaction of creams for revealing symptoms of post-burn itch. Next slide. So we recognized early on in the project that we wanted to be as inclusive as possible. Children living in families where English is not the primary language are actually more likely to be low income, live in crowded households, which are risk factors for burns. So because of this, we were eager to sign up for the first language barriers pilot project, so that preceded the MRT. We filled out a registration form, the PI consented, we updated our ethics, and we were provided with interpretation resources to use for the project, and the whole process was quite straightforward. I've copy pasted some of our wording on RISE. I don't know if that's helpful. And our goal was really to make use of the language barrier pilot interpreter tools when we couldn't access interpreters provided by the hospital in conjunction with clinical care. Next slide. So for the most part, we did identify and recruit patients in conjunction with their standard of care follow-up appointment at the outpatient burn clinic. And the benefit of this was families with English language barriers already had an interpreter with them as part of their visit. Either the interpreter was in person or the interpreter was on the language line iPad on wheels, and they would help us with the consent discussion. And just as a side note, this is a recruitment strategy we do for nearly all of our prospective studies when possible. Next slide. However, there were instances where we could not recruit patients at the time of their in-person visit. For example, the appointment may have been photo phone or virtual, or maybe the family was in a hurry to leave, or maybe a research staff member was unavailable. So when we did not have an interpreter, we would rely on staff members in our clinic who spoke more than one language, or preferably, we would use the on-demand interpretation services offered through the Language Barriers Pilot Project. Next slide. So the Language Barriers Pilot Project provided us with provincial language services interpretation tools. We had the flexibility to choose in-person, virtual, or phone interpretation at no cost. Of note, if we had not been part of this pilot project, we would have had to pay a fee according to the estimated costs shown in the right-hand column there. Next slide. So these are the instructions that the pilot team provided us, and we followed them to use an immediate phone interpreter. We did not have any issues. The phone calls would take up to twice as long as we had to account for the interpreter's role, but this wasn't a problem for us. Next slide. So for the consent process, the interpreter would also sign and date the consent form, and we would make a note of what language consent was done in. And immediately following consent, participants were asked to complete a 2-minute baseline questionnaire on their burn itch. So the interpreter was able to help with this too. And then about 6 to 10 weeks later, we followed up with families and asked them to complete a survey on product effectiveness. And we would also let them know the identity of their preferred product. And this follow-up was almost always outside of standard of care. So when needed, we would use the on-demand phone interpreter from PLS. Next slide. So looking back at our records, we never missed an opportunity to invite an eligible participant to be part of the study because of an English language barrier. From 45 eligible patients, 7 had limited English language proficiency, so about 16% of our population. 3 did not require an interpreter for consent, and for the 4 that did require an interpreter, 3 enrolled and 2 completed the study. In the end, few patients required an interpreter, but when we needed one, the interpreter was very important. And we would use an interpreter quite a bit over the course of a short period of time for a consent discussion, survey completion, or to share results. And we got a sense of the success of the interpretation from the discussion and questions that would naturally arise during a consent discussion or when we discussed going over a survey. And we're very grateful to Jennifer Clayton and the Clinical Research Support Unit for launching the next MRT pilot project. And our next step is to integrate the MRT pilot with our burn itch study. And Cynthia has kindly already helped our team sign up. So our plan is to continue making the most of interpretation offered through the MRT pilot when we can't access interpreters through standard of care. We're excited for this opportunity as it means we can continue offering the study to any patient that meets criteria regardless of English language barriers. And a potential advantage of the multilingual research team is that they will already be familiar with standard elements of consent, so we can have increased confidence that the consent process is done appropriately. Thank you again for the opportunity to speak today. I hope this was helpful. Thanks. Next slide.
Hi everyone, my name is Sahel and I'm going to be presenting my project titled Combining Community Engagement with AI, a New Model for Research Translation Equity. And this project was supervised by Dr. Melanie Murray. Next slide. So as some study background, English as an additional language, immigrant women living with HIV face multiple barriers in participating in health research as we have wildly English dominant study practices, and addressing these gaps is crucial for equitable representation in the scientific literature, as well as increasing accessibility of healthcare knowledge to EAL immigrants. For the study that we focused on, titled the BCC3 study, it examines the health outcomes of women living with HIV in Canada, and our study materials include consent forms, a questionnaire, and various knowledge mobilization pamphlets on heart and liver health, which are designed to improve health literacy and accessibility for women living with HIV. So this project combines artificial intelligence tools and community revisions to create culturally tailored translations. Next slide. So for our methods, we ensure to center community in all aspects. So first, we started with a community consultation and language selection meeting. So we had 13 EAL immigrant women living with HIV identify 7 key languages through collaboration with the Afro-Canadian Positive Network of British Columbia. These women agreed on the languages French, Zulu, Shona, Gujarati, Swahili, and Luganda as most pertinent for translation. Second, we began artificial intelligence trialing and testing. So 6 AI tools were identified based on App Store ratings and online community forums. These included LingvaNext, OpenL, Merlin AI, Quillbot, ChatGPT, and DeepL. And we then created sample translations of study materials, including our study questionnaire, consent form, and knowledge mobilization materials with each AI. We then brought these sample translations back to the community, where we had 11 bilingual immigrant women review the AI-generated translations for clarity and cultural appropriateness, selecting the top AI tools. And then from this, we hired 7 community members who were each fluent in one of the 7 languages, as well as English, to refine all the translated study materials from the AI for accuracy and cultural sensitivity, as well as bringing in the lived experience piece of living with HIV. Finally, our translations were completed and presented to community members at a knowledge mobilization event where we shared project development with attendees. The event included a panelist portion for immigrant women living with HIV to speak on their experiences migrating to Canada, a physician Q&A, as well as a health promoting goodie bag and lunch. Next slide. So for our final results, we had completed translations in Gujarati, Hausa, Shona, Swahili, Zulu, Luganda, and French. We then identified the best performing AI tools from the women's comments. So OpenL worked best for Luganda, DeepL worked best for French, and LingvaNext worked best for Gujarati, Swahili, Shona, Hausa, and Zulu. We also found that community input addressed linguistic nuances, including gendered perspectives and removal of stigmatizing terminology that the AI had included. Furthermore, participants appreciated the culturally tailored approach, improving engagement and accessibility. And AI-assisted translation may also be more cost-effective than traditional methods, as this allowed us to translate into 7 languages instead of 2 within the same budget. This also enabled our team to allocate more resources for community events, which further supported engagement and knowledge sharing. So in conclusion, this process enabled a more diverse community of women living with HIV to be involved with the research project. Next slide. So for conclusions of this project, this initiative highlighted the importance of linguistically and culturally competent research in addressing health disparities. By integrating community input and leveraging AI-assisted translation tools, we ensured that study materials were both accurate and culturally appropriate for immigrant women living with HIV. And the feedback-driven approach enhanced participant engagement and trust, and also set a precedent for more inclusive research practices. So moving forward, this model can serve as a framework for equitable knowledge dissemination, and may also lay the groundwork for future research efforts aimed at improving representation for underrepresented groups in research. We also hope to expand to a larger community of EIL women living with HIV, which would include different languages as well. And I've just shown on the side here a couple of our knowledge mobilization pamphlets in Luganda as well as Gujarati that the woman had completed.
Thank you so much, Sahel. Thank you so much to the three of you. You motored through that presentation. So while everyone is, I see there's 2 questions in the chat already. And before we turn our attention to the chat, I'm just going to mention I think Jennifer Clayton is here today as well. And I do see some questions about WHRI and BC Children's Hospital Research Institute. So one of the things that we are working on and launching is our own partnered project to support linguistic validation using generative AI. And so this is something that will be, this is sort of a bit of a teaser to let you know that if you are part of a study team that has a translation need, that you can reach out to myself or Jennifer, and we will be exploring how to support you in your translation needs, but also how can we assess some of the existing and available AI tools that Sahel mentioned in her presentation, and assess them even further for some of our needs. So when you're thinking about things like consent forms or knowledge products that are required to be translated in English and French by CHR now, please do keep us on your radar, engage with us so we can understand your needs. Okay, Cynthia, I think you can stop sharing. Thank you so much. And I will, so the first question is for Cynthia. Cynthia, this is a great initiative. Agree. Are you currently supporting studies exclusively at BCCHR or WHRI as well?
So I would say because the funding is provided by the Children's Hospital Foundations, so only studies at the BC Children's Hospital can participate in the pilot for free. But if like anybody who's from the WHRI would are interested in like covering in participating, but like covering the costs for the RAs, then that could also be a possibility for them.
Thank you, Cynthia. Another one for you. Out of curiosity and to understand the capacity of the MRT team, around how many team members are available for translation services?
So right now we do have 11 members with different languages. And we also have some help from like our family advisors. So we're able to support 7 languages for translation. And And also for like other languages, we're also like still recruiting for like other members, so we'll increase for that number. Yeah.
So other members to represent different languages.
Yes.
Wonderful. Thank you so much. This is such important work, the three of you. Thank you for that. Kristen just echoed that statement. Thank you. Is there a best practice or standard that we should consider with translations? We've used AI translation and had member checking, but are still concerned, is this standard good enough for health related information that's not clinical care? I'll open the floor to Sahel. Rebecca, I know Sahel, you've done translation work specific to like knowledge products as well, which I think Kristen is referring to. I'm happy to jump in, but would love to hear your thoughts first.
I think we used the community driven approach in order to see what community members' thoughts were depending on the AI. So it was very context dependent. So I'm not sure if there is like a best standard for working with it because for us it was very context dependent on the AI software and the opinions of the community.
Thanks, Sahel. Yeah, Kristen, what we are finding, and Jennifer, I see you've turned your camera on too. Feel free to jump in here. The work we're going to be doing is kind of very systematically assessing the AI outputs for translation for this exact reason. And so linguistic validation is a methodology that you can use. It does involve member checking, and we're going to be adding kind of an acceptability component to that, similar to what Sahel mentioned, where like people who do speak that language can validate it's kind of did they meet the mark?
Thanks, Nicole. If I can just add, so in one of the questions that's come up a lot in the work we've done around translation is what needs to be translated. And so we've had numerous conversations with the REB about what needs to be translated. And I think obviously knowledge translation products need to be translated, but thinking about consent forms, typically the REB feels that if you're intending to target a specific population or a specific group that you know is dominantly speaks a language. So, in Sahel's project, she was focused on certain groups of newcomers. So in those cases, what I meant to say is in those cases, it would be good to be translating all of your materials like recruitment materials and consent forms and things like that. But if you're just recruiting from the general population, it can be hard to know in advance what language you might want to translate things into. And then if you end up spending time and effort in translating a consent form that then is never used, the REB is quite comfortable with the approach of having non-English speakers signing an English language consent form as long as an interpreter is present. So it's really important to ensure that interpretation piece is there to confirm the understanding and then to have the individual sign the English language consent form. It's really nice if you can give people some materials in their own language. So some people are doing like a short brochure of what their study might be about. We have some general brochures as well on the public-facing website that have been translated into different languages that just talk about research in general, kind of general principles. So that's always something to think about too. Your surveys, do you need to translate all your surveys? It's good to have some of these thoughts and conversations about what you really need to translate versus what can you do with an interpreter, with the support of an interpreter.
Thanks, Jennifer. Yeah, and I think from just to build on that, something that we've something that we acknowledge is that this is an evolving space, and that's why, like Sahel's presentation, looking at the different tools that exist for translation is an important one. The other piece that can kind of add a different layer to it when we're talking about gender inclusive language, when we're talking about women's health topics, where we've seen AI get things terribly wrong. In terms of its outputs. And so, I think while we're all doing this work, we're hopefully training it to do better. At least that's that's our hope. The other thing too, just to flag, is that there are groups. There's a group that we featured at a research rounds a few months ago who's developed a Punjabi translation framework for women's health context. So there are community-based organizations that are actually trying to create more kind of guidance for us as researchers and the research community to do this work in a good way to make sure that the translation, because I think it's obvious that it's been translated from English instead of created in another language. So that's something to keep eyes on as well. Any other questions or comments? Okay. Well, if not, then we will give you 23 minutes of your day back, folks, to finish your lunch. And I will just let you all know that our next, we are going to move forward with regular programming in March. So March 18th is our next lunch and learn. And it is going to be focused on AI. So we're going to have another generative AI. So hopefully we'll pick up this thread around AI guidance.